Hi everyone. Rakesh sir is there?
Yeah, I'm there.
Yes. So I think we should get going. It's 8 o'clock.
8 o'clock. Just wait for just few minutes.
Okay.
Uh,
Yeah, people are joining now.
Yeah.
yeah, we'll join it. Eight five will start.
Yeah.
Couple of minutes.
Sure, sir.
So we have almost 50.
Yeah.
We start, yeah?
Yes, sir.
Okay. So, good evening, everyone, and welcome to this neuromuscular subsection meeting today. And the theme today is pediatric neuromuscular diseases. And on behalf of our convener, Dr. Vishnu, I welcome Dr. Mary Ipe and Dr. KP Vinyan. Dr. Ipe, madam, is a professor and head of department of pediatric neurology at Government Medical College in Trivandrum, and Dr. Vinyan is also professor and head of department of pediatric neurology at Amrita Institute of Medical Sciences, Kochi. So, without wasting much time, let me for the first session, Dr. Vinyan, and seeking hope through genes in neuromuscular diseases, and he is going to actually moderate the session. So, welcome, Dr. Vinyan.
Yeah, thank you, sir. Thank you, thank you, Vishnu. So this is a wonderful platform on discussing on the newer advancements in pediatric neuromuscular disorders, especially with the genetics into the play. We have our standard clinical neurology has got one more tool, and then we are getting better clinical patterns on this. And at this point, what we are going to do from our department is to give a kind of a basic basic two cases will be discussed, and Vaishak is the associate professor of pediatric neurology in our department, and Dr. Jyotsna has just left the department. She has finished her DM pediatric neurology, and she is working as the consultant neurologist in Apollo Hospital, Mysore. So over to Vaishak for the first case.
Hi.
Thank you, sir. I hope my presentation is visible.
Yes, sir.
Okay. So, good evening, all. Without any further delay, I will straight away start my case presentation. This is about a 12-year-old girl. She was studying in 5th standard with good scholastic performance, and she was a well-thriving child, running and overall a well-thriving child. Her symptoms overall started 2 years back in the form of easy fatigability. That was the first symptom. And her symptoms started progressing over the last 2 years, so much so that by the time she presented to our department, she was bedbound and she was fed through a nasopharyngeal tube. This is the pictorial representation of her symptoms. She started the symptoms as easy fatigability at 10 years of age. And after around 6 months, the initial symptom was that she was having easy fatigability while walking school. It was around 2 kilometers from her home to school, but she was walking, carrying her school bag. The initial symptoms that she presented was that she was having easy fatigability so much so that she was not able to walk, carrying her school bag. By next 6 months, it progressed that she was not able to do physical exercise like with cycling, yoga, dancing, etc. By the next 6 months, next month, it progressed that she has to, while walking, she has to walk, after walking like 50 meters, she has to rest a while. And she also had difficulty in getting up from sitting position. By next 6 months, there was a gradual progression from the lower limbs. Now she is having upper limb weakness also in the form that she was having difficulty in combing, overhead abduction of the hand, difficulty was there. Towards the last 2 months before she presented to our center, she was having a rapid progression, so much so that she cannot hold her neck properly. She was bedbound. She was already, or she was also having difficulty in swallowing solid, later liquid. And parents noticed that she was having difficulty in her there was hypophonia also. So with these symptoms, there was the negative history that was relevant with that she was not having any pain or cramps following any exercises. There was no second wind phenomena. The second wind phenomena I will detail in later. There was no urine discoloration, no edema, no recurrent vomiting episodes. There was no fever, rash, or joint pain, or even joint swelling. In the family history, what was relevant was that she was born out of a third-degree consanguineous marriage, and there was no other family history. On examination, this most striking thing was that she was having a severe generalized muscle atrophy, and along with that, she was having a drop head. Her higher mental function examination was normal. Her ocular movements were normal. There was no ptosis. Her voice but was having a nasal form. There was a weakness, lower limb predominant and proximal predominant, and upper limb also was involved. What was striking was that she was having a drop head, and the power was neck extensor were weaker than the neck flexors. Extensor power was 2/5, and that flexor power was 3/5. But however, her DTRs were preserved. In other system examination, there was no rash, no hair or nail changes, and no hepatosplenomegaly was present. So summarizing the case, here we have a 12-year-old girl with a chronic proximal and lower limb predominant weakness with prominent axial involvement in the form of hypophonia, bulbar dysfunction, neck drop, and a preserved cognition in the background of a third-degree consanguinity. So the anatomical localization was pretty clear. It was muscle, and a far-fetched possibility of anterior horn cell was kept, but preserved DTRs ruled out against that. With this, the etiological possibilities we kept with upfront, it was inflammatory myopathy because it was the age group and there was a rapid progression. But she was not having any cutaneous manifestations like heliotropic rash or any nail changes. That was something odd. Even then, we thought that it could be a dermatitis JDM or a polymyositis. Another odd feature was that she was having prominent EC fatigability. The presentation itself was with EC fatigability rather than a weakness. Weakness came into picture later. So that was something odd for an inflammatory myopathy. Another soft sign was that neck extensors were weaker than flexors. Usually in inflammatory myopathy, it's neck flexors that are weaker than the neck extensors. Because she was having a third-degree consanguinity, EC fatigability, we thought that a metabolic myopathy also could be a possibility. But what was striking was that she was not having the typical metabolic myopathy symptoms like muscle pain, myoglobinuria, cramps, etc. The only thing was that she was having exercise intolerance. In the last possibility, we kept a possibility of muscular dystrophy because considering the age and all, and third-degree consanguinity. But a rapid progression in 2 years, so much so that a running, walking child was bedbound in 2 years was something odd for any muscular dystrophy to present. So with these etiological possibilities, we started our investigations and we found that CPK was a bit high, not a bit high, it's high, not in the ranges of a muscular dystrophy, but just at 1,000. Her metabolic parameters like lactate, ammonia, ABG, even TMS, GCMS was normal, except for non-specific low carnitine levels, which most of the kids who are malnourished will be having. Her echo was normal. We did a muscle biopsy and we did a muscle MRI. Her nerve conduction study was normal. ENG was showing a myopathic pattern. So this was the muscle MRI that we got. The findings were not that robust, but this is the MRI of the T1 stereo images of the axle of the lower limb legs. In the left side, tibialis posterior, you can see there is like a mild streaking hyperintensity left side. And the right side also very mild only, not very very strong or very striking, but it was abnormal. And the diagnosis was it could be myositis or a muscular dystrophy. So with the possibility of an inflammatory myopathy, we started injection nitroprednisolone, gave for 5 days and followed by oral prednisolone. And following this, she had a significant improvement in muscle power. By the time of discharge, she was able to walk and she was able to hold her head without a drop. So further immunotherapy, methotrexate, etc. were planned. We thought we will be waiting the muscle biopsy report. But in the muscle biopsy report, what came, it was like it ruled out an inflammatory myopathy. But what it showed was that the muscle fibers were having fine sieve-like vacuolations inside the fibers. Unfortunately, I am not having the picture of that muscle biopsy, but this is what I got from an article. This was something like this. The muscle fibers were started with vacuoles, as you can see, which were having highlighted using Sudan. So at 12 years, a child presenting with lipid myopathy, the most common cause we thought was a glutaric acidemia type 2, which proven in the whole exome, it was confirmed that she was having glutaric acidemia type 2C. It was a VUS, but all these functional, the investigations proved that it was significant. In the further course, we already had started riboflavin. The further course, we continued the high dose riboflavin. We had added CoQ, carnitine, and we discharged her avoiding to advise that avoid fasting, avoid high fat diet, etc. And at the last follow-up, that's after 2 years, she's completely back to baseline with a power grade by 5/5 in all joints, and her last CPK was 158. So before going to the details of a metabolic myopathy, I'll just have an overview about the metabolism of the muscles. So skeletal muscle, like any other tissue in the body, needs ATP for the proper functioning. For skeletal muscle, there are mainly 5 sources where the muscle will be getting ATP. This is what I have enumerated. The first is glycogen or glucose metabolism, whereby glycogen is metabolized to glucose, where glucose is again metabolized to pyruvate. In this process, ATP is produced. Second way is lipid metabolism, where the free fatty acids are undergoing a process known as beta fatty oxidation in the mitochondria, and as the end product, we get acetyl-CoA. This acetyl-CoA in turn goes to Krebs cycle, which produces ATP again. The third is oxidative phosphorylation, which is otherwise known as respiratory chain, mitochondrial respiratory chain, where the reducing equivalents like NADPH, NADH, FADH, etc., are utilized to produce ATP. Then other 2 minor pathways like creatine kinase reaction, urine nucleotides, etc. So the dysfunction of glycogen or glucose metabolism lead to glycogen storage disorders. Dysfunction of the lipid metabolism pathway lead to FAOD, fatty acid oxidation defects, and dysfunction of the oxidative phosphorylation lead to mitochondrial myopathies. So these 3 constitute the chunk of what we call as metabolic myopathies. Before going further, I'll just have an overview of fatty acid oxidation defects, how it is helpful in the muscle, because our index case was having glutaric acid type 2, which is a type of fatty acid oxidation defect. So from the blood, fatty acids enter the cytoplasm. This is the cytoplasm of the skeletal muscle. Fatty acids enter the cytoplasm of the muscle but after entering the cytoplasm, now this muscle, this fatty acid has to enter the mitochondrial matrix. But fatty acids cannot cross these 2 mitochondrial membranes. There are 2 mitochondrial membranes, outer and inner. To pass through that mitochondrial membranes, these fatty acids need the help of carnitine. So that's what carnitine does. Carnitine shifts fatty acid from the cytosol of the cell to mitochondria. So through a reaction, the fatty acid is converted to acyl-CoA. Acyl means it just means it's not specific. Acyl just means it is a fatty acid side chain. Acyl-CoA combines with carnitine, and then it is shifted into intermembrane space, then again into mitochondrial matrix. So in this process, 3 transporters are taking part. CPD1, that's carnitine palmitoyl transferase 1, CPD2, and CACT, that's carnitine acyl carnitine transferase. So these transport proteins, by virtue of these transport proteins, acyl-CoA enters the mitochondrial matrix. Now from here, the acyl-CoA, it passes through a cycle, including 4 enzymes, which is known as beta oxidation. And at the end product, we'll be having acetyl-CoA. So this is the end product of beta oxidation. Acetyl-CoA then further goes to Krebs cycle to produce ATP, or acetyl-CoA can be channelized to produce ketones. Now, any dysfunction at any of this point can lead to what is known as FAOD, fatty acid oxidation defect. In our case, the first step of the beta oxidation, that is acyl-CoA dehydrogenase, this step is linked with electron transport chain. That's what is depicted in the second cartoon, where FADH2 is produced to FAD. Meanwhile, electron is transported into the respiratory chain through something known as ETF, that is electron transport factor, electron transport flavoprotein. This complex is what is deficient in the disease known as multiple acyl-CoA dehydrogenase deficiency, MADD, otherwise known as glutaric acidemia type 2. This enzyme is needed to propel these 4 steps further. So if there is any dysfunction in this ETF or ETF dehydrogenase, then acyl-CoA dehydrogenase cannot function properly, and the further steps, distal steps, are blocked. So it's not only for a single acyl-CoA dehydrogenase; it's for short chain, long chain. All acyl-CoA dehydrogenase will not be functioning properly if there is a dysfunction in ETF or ETF-DH. So that is why this disease is known as multiple acyl-CoA dehydrogenase deficiency. So once this step is dysfunctional, what happens is the proximal step, there will be accumulation of the proximal metabolites, which will be having a backflow to the bloodstream, where carnitine, SIL, everything will be lost, and there will be carnitine deficiency, and there will be energy deficiency. And in the muscle, in the blood, through a test known as TMS, that standard mass spectroscopy, the carnitine profile can be, using the carnitine profile, we can delineate out of this where is the main port. It could be in the 4 enzymes of the beta oxidation, or it could be at the level of the transporters. So this is an overview of FAO, that's fatty acid oxidation defect. So how does a metabolic myopathy present usually? The most characteristic symptom of a metabolic myopathy is which is known as dynamic symptoms, where a muscle, when it is under action, will be having symptoms. Like when someone is doing exercise, maybe prolonged or maybe an intense exercise, the subject will be experiencing muscle cramp, pain, weakness, sometimes high CPK, myoglobinuria, which will be evident as cola-colored urine. These are known as dynamic symptoms, which is very characteristic of a metabolic myopathy. And this can be precipitated either by exercise or even by prolonged fasting, infection, even high-fat diet also. Metabolic myopathies also can have static symptoms, like static myopathy will be, may be there. And if when static symptoms are there, mostly it will be in the limb girdle pattern, and most of the time there will be axial involvement in the form of hypophonia, bulbar symptoms, etc. And it could be combined also. So when the presentation is as dynamic symptoms, it is pretty much easy that okay, we can suspect a metabolic myopathy. But the confusion occurs when a metabolic myopathy presents only with static symptoms, as it was in our case. Looking back, in our case, there was very few signs or symptoms to say that it could have been a metabolic myopathy. Like there was a 3rd-degree consanguinity, there was excessive fatigability, as I already told, compared to a weakness. Fatigability was more from the starting, and also there was a characteristic neck drop. So these were the only symptoms when looking back that had pointed towards a metabolic myopathy. So the concept that metabolic myopathy present only with dynamic symptoms like muscle cramps and pains should not be there. Static symptoms also may be presentation of metabolic myopathies. I'll just have an overview about the most common metabolic myopathies. First one is a glycogen storage disorder. The most common and most well-known thing is Pompe disease, otherwise known as GSD2. It's an entity with static symptoms, where there will be no dynamic symptoms like muscle cramp, pain, etc. It will be a fixed myopathy with cardiomyopathy. Glycogen storage disorders which can present with dynamic symptoms are mainly two: GSD5, otherwise known as McArdle disease; GSD7, otherwise known as Stargardt disease. Compared to an FAOD, dynamic symptoms of GSD have some differences. GSD presenting as dynamic symptoms will be mostly precipitated by isometric exercises like lifting a heavy weight, etc., or less intense but sustained like swimming, running, etc. Also, the symptoms like pain and all mostly will be developing during the exercise or shortly after the exercise. Fistus foramen ischemic thrustus, which is not usually done nowadays in the clinics, because it's a cumbersome test. If fist is done, what it will the report will be like, there will be a failure of rise in the serum lactate. Usually, normally there should be rise in serum lactate when there is after exercise, but that rise in serum lactate will not be there in glycogen storage, because glucose, the end product is lactate, and when the pathway is blocked in between, lactate will not be produced. There is another interesting phenomenon which is known as second wind phenomena. I'm sure everyone will be knowing. It's a characteristic feature of GST5. Another feature is out of wind phenomena. That's characteristic of GST7. Second wind phenomena means a child or a subject who is having some symptoms, like a child walks for 20 meters and then he develops a muscle cramp or weakness and he rests for 2-3 minutes. After that, his symptoms are resolved, or next he can, after this resting, he can walk for maybe 50 or 60 meters. That is not a second wind phenomena, which is characteristic of GST5. When someone is having a high carbohydrate meal, there will be a weakness, more weakness. That is known as out of wind phenomena. In FAODs, dynamic symptoms mostly are present. The most common entity associated with dynamic symptoms in FAOD, one is CPT2 deficiency. Static symptoms mostly MADD, as in our case, or very long chain acyl deficiency. Compared to glycogen storage diseases, in FAODs, symptoms usually are induced by infections or fever. And also the symptoms develop mostly like hours after exercise, compared to glycogen storage disease, where it is immediately or during the exercise. And there will be involvement of other systems like cardiomyopathy, hepatopathy, etc. And there may be presence of hypoketotic hypoglycemia. And as I already told, FAOD, if there is a suspicion, TMS will be very useful because it will be showing altered carnitine profile. Then the third one is a mitochondrial myopathy. As everyone knows, it will be having a multi-system, multi-neuraxial involvement. Strikingly, they will be having external ophthalmoplegia and ptosis. The most common entities that we see in our clinical practice, one is Golgi and others co-curations, MELAS, etc. Coming back to our case, there is multiple acyl dehydrogenase deficiency, or otherwise known as glutaric aciduria type 2. There are three types. Type 1 and 2 are the neonatal onset, and type 3, as in our case, it is the late onset MADD. The most important feature of this disease is that it is very highly responsive to oral riboflavin. Along with the riboflavin, we need to supplement with CoQ and carnitine also. So the take-home messages are metabolic myopathies can present with pure static symptoms, as I already shown in our case. And it should not be like if there are no dynamic symptoms, it's not metabolic myopathy. It's not like that. MADD should be considered a differential diagnosis in all cases of idiopathic inflammatory myositis, like JDM or polymyositis. Neck drop, in many articles, it is for that. Neck drop is a characteristic clinical features of MADD in the relevant clinical setting. And in many metabolic myopathies, as I already told, CPK may be normal at the resting state, like CPT2, carnitine palmitate transferase 2 deficiency, may be having CPK at the resting period. In some cases, genetic evaluation upfront can avoid muscle biopsies. Like in our case, there was another corollary case where the child presented with pain and weakness, and we straight away sent a whole exome, and it was positive for GA2, and we avoided a biopsy. The most common 3-4 metabolic myopathies that should be kept in mind are one is late onset Pompe disease, which can present multiple ways, GST5, 7, MADD, as in our case, CP2, and VLCAD. Okay. I would like to thank Dr. Anita of NIMHANS for biopsy and Dr. Sheila of our genetics department.
Yeah, I think without further delay, we will go to the next case. Jolson, you can share your screen.
Dr. Vinayan,
Yes.
there's a question from Dr. Parthare.
Yeah, we will have that at the end. No, I will have it at the end. No.
Okay, at the end. Perfect.
Because there are a lot of
yeah. Sure.
Are my slides visible?
Yes.
Yes. So good evening, everyone. I'm grateful for this opportunity to be able to present on this platform. This child is an 11-year-old girl who presented with a distal upper limb weakness. She was the only child to non-consanguineous parents. In May 2019, for the first time, she presented with an asymmetric distal weakness of the upper limbs and right more than left, in the form of a change in handwriting, difficulty in writing, buttoning, opening bottle caps. So there was a significant distal upper limb weakness. On examination, she was noted to have significant wasting of both hands, thenar more than hypothenar, and there was also weakness of the intrinsic hand muscles. The upper limb reflexes were, however, normal, and no other neurological signs were present. There were no other weak or wasted muscles. At this point, the possibility of a focal anterior horn cell disease was considered most probable. An upper limb onset neuropathy was also considered. But unfortunately, at this point, there were no pictures taken at this visit. The NCV showed reduced CMAP amplitude from bilateral median ulnar and right peroneal nerves. There was also a conduction velocity slowing of bilateral ulnar and left medial nerve with normal sensory parameters. And the EMG showed a neurogenic pattern only in the right flexor digitorum interosseum muscle. So the conduction velocity slowing suggested more of a neuropathic pattern. An upper limb motor predominant neuropathy was considered and further evaluation was planned. But unfortunately, the child was lost for follow-up. She went on to take some complementary treatment, did not turn up. And 2 years later, in May 2021, she came with further progression in the hand weakness and wasting. And all the functions that she would do had worsened in those 2 years. And there was a recent onset over a few months of weakness of proximal lower limbs. There was a change in gait. On examination, she was noted to have brisk upper limb reflexes, sluggish reflexes in the lower limb, both knee and ankle, with an extensor plantar. So, and she was also noted to have mild spasticity and mild unsteadiness, which was very apparent on walking. There were no clear cerebellar signs at this point. So these are the examination findings. We can see that there is a significant wasting of the hands, both hands, but more so on the thenar aspect. And then she has a change in the way she held the pen. And there was a significant weakness noted of the dorsal and palmar interossei and the thenar muscles with a sparing of lumbricals. And there was no wasting of the lower limbs, as it is evident by this photograph. So NCV at this point showed a reduced or absent CMAP amplitude from many more nerves. So now bilateral peroneal nerves were involved and tibial, femoral and right median nerves were involved. Distal latencies were also prolonged from more nerves and there was conduction velocity slowing reported from more nerves than the original report 2 years back. And there was a worsening of motor conduction parameters in those nerves that were already affected. And again, sensory nerve action potentials were normal. So this suggested a motor neuropathy, a predominant axonal with demyelinating characteristics in the form of conduction velocity slowing and prolonged distal latencies. Needle EMG showed large motor unit action potentials in more muscles now in the muscles of the lower limb and upper limb with discrete recruitment patterns, again suggesting a neurogenic pattern of involvement. So at this point, with the UMN findings and unsteadiness, it more looked like the scenario looked like a progressive multineuraxial syndrome with a predominant LMN component. We had an upper limb onset neuropathy, a proximal lower limb weakness. We also considered with that proximal lower limb weakness a radiculopathy or an associated myopathy. The NCV, however, suggested an apparent mixed, that is an axonal plus demyelinating type of a neuropathic pattern. With that, human findings were there. So overall, the field was that of a neuropathy plus syndrome at this point. Extensive workup was done to rule out acquired, that is nutritional and immunological causes of neuropathy plus syndromes. And MRI brain and C-spine whole spine screening were normal. Blood routines, metabolic profile, CPK all were normal. CSF was done to rule out immunological syndromes like CIDP, treatable, which were treatable, that was normal. Nutritional, from the nutritional perspective, vitamin B12 was normal, vasculitic workup was normal. Again, genetic syndromes which could present like pure motor neuropathies, porphyria, urine porphyrin was negative. And it was an unusual syndrome, not characteristically fitting into anything known. Then a genetic possibility was thought of. A genetic vitamin responsive reversible neuropathy like a riboflavin transporter defect, which is well known, was thought of. And at this point, megavitamins were started, keeping the possibility of a genetic neuropathy plus syndrome in mind. Prior to that, for the benefit of doubt, empirically, she was given steroid also from the immunological perspective. So the whole exome showed a mutation. It was a homozygous mutation in the SLC5A6 gene, which was of both maternal and paternal origin. It was reported to have autosomal recessive pattern of inheritance and causing neurodegeneration, which is biotin responsive. So how to interpret this report? What this gene meant, what the report meant is that the role of SLC5A6, I will explain in brief. SLC5A6 is a gene which encodes for the sodium multivitamin transporter, that is SMVT. This SMVT or the sodium multivitamin transporter is seen in many, many biological membranes, all plasma membranes, blood-brain barrier, blood-nerve barrier. This transporter is there across many biological membranes. And there are solutes that are specific to this transporter, that is in context of sodium multivitamin transporter, it is the biotin, pantothenic acid, and the alpha-lipoic acid. And some other molecules like iodide are also involved. Clinical manifestations of this genetic defect that leads to a dysfunctional or a lack of function of this multivitamin transporter will simulate the manifestation of that particular vitamin deficiency. So it is transporting biotin across the membrane. So the clinical manifestation of this transportopathy will mimic that of a biotin deficiency. If the mutation is a truncating one or a severe one leading to a totally dysfunctional lost protein, lost transport protein, that is this vitamin transporter, then the manifestations are severe. They may be multisystemic with multineuraxial. If we take the example of a severe biotin deficiency or biotinidase deficiency, we can imagine a child with alopecia, rash, diarrhea, and those are the systemic manifestations. The neuraxial manifestations being infantile spasm, severe developmental delay, hypomyelinating neuropathies, those kind of syndromes. So severe mutations in this transport protein leads to a severe phenotype, whereas mild missense mutations lead to milder phenotype. They lead to a partially functional protein and therefore a milder phenotype. So overall, this is a transportopathy. The concept is of a transportopathy where this transporter protein, which is supposed to transport across through a sodium gradient some vitamins across many membranes, that is defective. which is why we are having those symptoms that corresponds to vitamin deficiency states of these specific implicated vitamins. Again, further inputs from the genetic team was sought because this was reported as a VUS, a variant of unknown significance. And it was suggested that one way to prove the pathogenicity was to rule out a biotinidase deficiency itself. And that was done. So the child did not have biotinidase deficiency, serum biotinidase level was normal. And then it was suggested to do an in silico prediction analysis. So the in silico prediction analysis also reported that this mutation could be probably pathogenic. So this is a new entity, a transportopathy, and the plan was, and 1 minute. And the plan was to initiate the precision treatment after receiving inputs from the genetics and the international collaboration. Supplement vitamin, specific vitamins implicated in this transportopathy were initiated. That was biotin, alpha lipoic acid, and pantothenic acid. So these were the biochemically specific vitamins that were initiated as precision treatment towards this particular transportopathy. And then the earlier multivitamin cocktail that was initiated was continued. So this was a video that was before the initiation of treatment. So we can see that the child has a very significant proximal lower limb weakness in trying to rise up from the sitting or squatting position. So that was almost 2 years back. Now this is the present latest video. We can see that the child is able to rise on her own without any support and without any external support. And that showed a fairly dramatic improvement for this mutation. And she also reported a significant improvement in the bulk of the hand muscles, and weakness of the hand muscles had improved. So NCV also showed a significant improvement in the CMAP amplitudes of most of the nerves compared to the previous study that was done 2 years back. So we went on to report this by pulling in data from another case of our own center and with the international collaboration, data from multinational centers. 5 children from 3 families who all had missense type of variation of this SLC5A6, who all presented with progressive motor neuropathies were reported. So this was a fairly mild presentation because of a missense mutation. Missense mutation is where only a single amino acid is substituted in the particular gene, which leads to a fairly functional protein, partially functional protein. So the take home at this point is that treatable neuromuscular disorders are expanding, and there is a promise of improvement in disabilities. It is not like the classic neuromuscular DMD SMAs of earlier days where the treatment is limited. There is this entity of a genetic neuropathy plus syndrome, that is the transportopathies. When faced with a patient, a precise genetic diagnosis with proper inputs from the geneticist and the lab is the best way to proceed, because of the possibility of precision medicine targeted treatment options, which can have a profound implication on the quality of life. And multidisciplinary collaborative efforts are the way forward. I will conclude by underscoring the point Dr. Vaishak made initially. Treatable genetic neuromuscular disorders are increasing with time. Seeking hope through the genes and pushing for an early genetic diagnosis for these treatable entities is where the future lies. Thank you.
Thank you, Jolsna and Vaishak. You can come on board. I think we have 2-3 minutes now, Rakesh. Yeah. So there are some questions here. Vaishak, you can take that question. It is already you have answered. One question is why in your case it is a VUS, and then you are telling that it is pathogenic.
Yeah. So the input we had given was that suspicion was glutaric acid type 2 itself, but the mutation was not, this particular mutation was not reported previously. That's why they have given a report of VUS. But the biopsy was showing suggestive of lipid myopathy, and also the clinically also there was riboflavin responsiveness. So everything was fitting into that it's pathogenic only.
Okay, so what about that question of metabolic screen was normal? And
Yeah, that was what I wanted to highlight. So usually TMS in metabolic myopathies and metabolic diseases, we expect that TMS, that tandem mass spectroscopy, will be having abnormality. But in our case, it was normal, and it will not rule out a metabolic disease because it depends. TMS depends on at what stage you are taking the sample. If it is now out of the period when the child or subject is having that issue, like if the child is in a stable state, TMS may be having false negative values. So what we can do is we can have in suspected FUDs, we can have a fasting sample, like at least for 12 hours and all. But even that is not recommended because sometimes 12 hours fasting can precipitate an acute metabolic crisis. It could be life-threatening also. So TMS, GCMS, these metabolic testings should be read in the background of when it was done, where it was done, because there are many technical issues. But for the genetic diagnosis, whole exome, such technicalities are not there. So here, both reports were actually complementary, the muscle biopsy and the genetic report. TMS did not help us in this case, actually.
And what about this fatigability? So this is when we say fatigability, immediately our thoughts is to the neuromuscular junction.
Yeah.
So what kind of fatigability was it?
It was not a neuromuscular. The NMJ disorders, the characteristic clinical features will be having the extraocular muscle. There are very rare congenital myasthenic syndromes where ophthalmoplegia and ptosis are not there, like GBT and all, which are having a limb girdle myasthenia pattern. Apart from that, most of them will be having ptosis and ophthalmoplegia.
And there is a question on steroids, because both these cases, even though we say metabolic disorders and we got the diagnosis, we gave steroids here and it showed some improvement. What could have been the mechanisms? Any thoughts, Vaishak, in your case?
In my case, actually, it's not clear how did it work actually, because there are some studies that in specifically in MADD, people have tried steroids before giving riboflavin. There is one study also, but in studies they have shown that there is no improvement. Only with steroids there is no improvement. But contrary to that, in our case, even before giving riboflavin with the steroids itself, child had a significant improvement. Although it was not a complete improvement, was achieved only after adding riboflavin. But definitely there was a significant improvement with steroids. So the exact mechanism is not clear. But previous studies have shown that
there was a CPK elevation also. No,
yeah, CPK elevation was there. It was 1000, just at 1000, which returned to normal after riboflavin.
Okay, Jolsna, what is your thought on this steroid? And then there was an improvement with steroid there.
Yes, sir. Even otherwise, steroid is known to improve these kind of degenerative syndromes, sir. And in the context of a myopathy or a neuropathy, where active degeneration is going on, there is reports of improvement, probably by the anti-inflammatory effect of the steroid. So that is why probably we got that improvement. Sir.
Yeah, it may not be anti-inflammatory alone. Probably it can work at multiple levels. There can be, say, that like we had studies on ataxia, telangiectasia, which shows that it is actually the genetic upregulation which is happening with steroids, and probably the mitochondrial functions are improving with steroids. So there are multiple levels. Actually, Indrishish has given that there can be a mitochondrial dysfunction, and then that can improve that steroid. So there are multiple ways it can work. So the steroid improvement may not suggest that there is a real anti-inflammatory component. Even in many genetic disorders outside the neuromuscular system also, we use steroids and there is some improvement with that. So, but here the point here is when we have a genetic diagnosis, we can have a targeted treatment. So even many cases we give cocktails of vitamins, but that is not very targeted. We give like that and we are not very sure whether it's working or not working. But when we have a clear diagnosis, like in the second case or in the first case, so where we know that this is the cofactor which is working and there is a pathophysiological mechanism behind that, we are more enthusiastic, and then we will give at a higher dosage, and it is more of a mechanistically driven therapy rather than our usual empirical therapy. So that is the message from these two cases. And over to Dr. Akeshani. Anything else to add?
Yeah, I think Dr. Anand's case also tells us the role of muscle biopsy actually. You know, which patients of neuromuscular diseases, I mean, biopsy can be really very, very useful. It can just pick up the treatable causes. You know. So
Vaishak, you
So
can add to
very
that,
highlight.
see, because without that muscle biopsy, our VUS would have been a little difficult to prove or disprove.
Yeah,
I mean,
because the TMS also was not suggestive. So apart from the biopsy, actually there was nothing to no hard fast evidence to point towards a metabolic myopathy, let even MADD in the starting.
So definitely muscle biopsy is a useful thing even in this era of genetics.
Yeah,
But,
absolutely.
yeah, so that is one message from that first case.
And I think Dr. Jyotsna case was absolutely fascinating. I mean, this case, unless you do a full extensive workup, it is practically impossible to really diagnose and ultimately treat the patient. Patient recovered so well.
Yeah, so the points in that case was we were not able to get one of the few things when we look back. It was not fitting into any classical syndromes which we have seen. Okay, so it was there was some the UMN dysfunction also towards the end, and then we are not very sure there was some mild ataxic element. So we were, but it was a neuropathy plus syndrome in the beginning. So that is one thing which was helping us. And then the other thing is it is basically it was the point which we would like to highlight is when we have this kind of unusual cases, and there are certain reports already, like riboflavin transporters were there, riboflavin transporter neuropathy and other biotin neuropathy. So this when you have unusual cases, it is always to add this genetic evaluation as one of your tools at this point. Without that, we will not be able to have that kind of definite targeted treatment. And because of that targeted treatment only, especially that pantothenic acid and alpha lipoic acid, which we usually never use in our usual cocktails, the kind of improvement we got probably. So that is our take on that case.
Excellent.
Yeah, Vishnu.
may I add on?
Yeah.
Yeah, I know there's a lack of time. We'll just, but one thing is that our biopsies, most of the biopsies that we are doing, even in adult neurology, is going a reverse way. We are getting the genetics first, and then sometimes for a validation or the functional studies, we're doing the biopsy on the reverse side. But that's one thing. The usual algorithm that we make, biopsy followed by this one. Now most of the algorithm has been reversed in a good way, that we might avoid unnecessary biopsies also. So you do biopsy only those cases where you need specifically for a functional characterization. That's something to that. And the second case was really interesting because I mean a lot of cases we diagnose as we get a common basket diagnosis of HSP plus and myeloneuropathy plus syndromes, which we don't get a diagnosis. I think this was a good. I think we as adult neurologists we may not be seeing that many cases like this. It's a good eye-opening case for us also.
Nice. This was a juvenile onset, so many cases will come to you also.
Yeah. So we may be missing a lot of cases. We may not, unless you do a genetics, we may be missing a lot of cases.
Yeah.
Dr. Jyotsna, there is one question by Dr. Ray. How do we explain the FDI predominant presentation followed by proximal weakness? There is no specific phenotype. And how can we refine the approach? Any ideas?
At this point, we don't have the phenotype is not so robust, because in the literature that is already reported earlier, there were the severe cases of SLC5A6 were reported to have very severe multisystem, like global developmental delay, failure to thrive, that kind of a spectrum. Now it is for the first time that milder phenotypes are reported, and which were presenting as motor axonopathies or a motor neuropathy kind of a presentation. Now, which muscle is more involved, which is less involved, that kind of a phenotype has not evolved. In our case, we had a predominant EMG finding from the flexor digitorum interosseous muscle. From the clinical perspective, there was a differential affection of muscles like palmar dorsal interosseous, thenar muscles were more affected than the lumbricals, because of which she had a peculiar hand grip. So why this genetic mutation affects a particular muscle more than the other, that is not known. And again, the phenotype has not evolved. With our case, it is restricted to this kind of a differential affection. But in other children, this kind of a differential affection has not been reported. It is coming from a geneticist's literature, actually. So probably they have not characterized it, or probably we need more kind of reports or children so that we can develop a better phenotype.
Yeah, see, the bottom line is that, see, this is as Vishnu has already told, this is one thing which we have not diagnosed many times before. And what kind of initially, actually, if you look back in this case, initially, because of that asymmetric upper limb involvement, our first diagnosis was a kind of a focal anterior hornsel disorder, like a Hirayama. We asked for an MRI and a dynamic compression because that is the literature which supports those things. But this is a new tool which is evolving with time, and then there is a clear pathophysiologic and neurobiological approach here. So our clinical patterns have to evolve. So I agree with Pathare because here that was the real issue for us. We were not able to fit it into a clear phenotype because this was a distal upper limb to start with. Then there was a proximal lower limb predominance. So that is not clearly a one localizing feature. So we may have to put in multiple localizations, and then this transportopathy helps in that because it affects everywhere. Because it is, and if it is a severe phenotype, it becomes a multi-system disorder. It is not a only neurological disorder. So with that, I think we will close. It is a very interesting session, and thank you for the neuromuscular team for giving us this opportunity from the Department of Pediatric Neurology, Amrita Institute. Thank you.
Thank you, Dr. Vinin. Thank you so much. Excellent cases. Dr. Mary, madam, you will start now.
Yes, thank you, Dr. Vinay, Dr. Vaishak, and Dr. Josna. We will go on to the management of scoliosis. As an introduction, Dr. Eshmi will show a panoramic view of cases of spinal muscular atrophy. Please share your screen. Dr. Eshmi is a postgraduate student at the Department of Pediatric Neurology, Government Medical College, Trivandrum.
Thank you. Hope I'm audible. At the outset,
Slideshow, please. Slideshow.
Okay. At the outset, I would like to thank the organizers and Marriott Madam for giving me this opportunity to present in this platform. I will be discussing in short some of the musculoskeletal manifestations of SMA. The natural history of SMA being very complex and variable and varies depending on the different types of SMA. The predominant clinical feature of SMA being the muscle weakness and atrophy, and the muscle weakness being symmetric, progressive, and more of proximal muscle involvement rather than the distal muscle involvement. And here is the child, child with SMA who is a walker, who is an ampuller, but obviously showing difficulty in getting up from kneeling down position, which is suggestive of a proximal muscle involvement. And here is another feature, which is polymini myoclonus, which is also seen in various anterior-hornsel diseases and seen associated with SMA also. It's also which is actually a hyperkinetic movement disorder, and it's usually seen in outstretched hand while maintaining a posture. And this is characterized by very low amplitude, intermittent, arrhythmic movements of hand, usually involving several fingers. And there could also be axial weakness involvement in SMA. And as the child grows, there will be increasing progressive weakness in the back muscles, and this results in the pulling of spine by the gravity and resulting in the scoliosis, which is actually the curvature of spine from side to side, making it out of the vertical normal plane. And signs of scoliosis are being uneven shoulder and uneven hip, as seen, as we could appreciate from these images. And as the child grows, since this is a progressive scoliosis, as the child grows, there will be increasing severity of the scoliosis. And it is observed that the progression of scoliosis is more associated with the children who are non-ambulant than who are able to walk. And in this image, you could appreciate a smaller child with a very mild scoliosis. Also, And in this image, we could see the child with very mild scoliosis, while in an older child, we could appreciate a very severe scoliosis. And the scoliosis could be either with a single curve or with a double curve, as seen in this child. Almost 75% of the SMA children with the scoliosis will be having a single curve. But here we could see the double curve, that is two convexities to either side, and seen almost in 1/4 of the patients. And another feature that could be seen associated with the scoliosis is the pelvic obliquity in SMA children. And this is actually a condition in which the pelvis is seen uneven and rotated downward on one side, and which could actually result from the muscle weakness, contraction of the hip, or can be secondary to a combination of two. And the presence of this early pelvic obliquity and along with the scoliosis is one of the most significant orthopedic problem that we have to face in children with SMA. And this can result in hip dislocation or hip subluxations. And another detrimental effect, other than affecting their appearance, is in case of scoliosis, is that its affection onto the chest, shape of the chest. Severe affection of the shape of the chest, resulting in respiratory dysfunction and reflux. And there could also be loss of ability of the child to use the arm, and loss of sitting balance also, and signifying the need to attend to the scoliosis at the earliest. And regarding the management of the scoliosis, one of the main is bracing. Here is a child seen wearing high spinal jacket, whose upper rim level is just below the axilla, so that the child can freely use the both hands. And this is the child wearing knee orthosis with ankle foot orthosis. And usually, with the help of braces, there can be significant improvement of quality of the life of the child, and which can help in supporting the trunk, and which makes the giving care and posturing a little bit easier. Regarding further evaluation and management of the scoliosis, Ashok sir will be detailing. Thanks again.
Thank you, Dr. Reshmi, for that panoramic view. And Dr. Ashok Ramakrishnan, kindly enlighten us with your management of scoliosis. Dr. Ashok Ramakrishnan is Professor of Orthopedics at Government Medical College, Trivandrum. He is a trained spinal surgeon, and he's doing scoliosis surgeries for many neuromuscular cases. Over to you, Dr. Ashok.
Good evening. Are my slides visible to you?
No, you have not shared your slides yet. Yes. Slideshow.
Yeah. Is it fine now?
Yes.
Thank you. Thank you, Meera. First of all, at the outset, thanks for the invitation, and I really appreciate. It's quite an honor for me to be a part of this elite group discussing something which is quite close to the heart. To be honest, I feel a bit out of place in this group, because in the previous discussion, the only word I understood was when Sir mentioned Hirayama, because that is one area we will come in and we fix the cervical spine extension. All the other things were all bouncers for me. Before starting any talk on neuromuscular scoliosis, I think this is where we should be starting, because there are many things which we can do, many things which we shouldn't be doing, and we should know where to draw a line, what to do and when not to do. We should know our limitations, basically. So neuromuscular scoliosis is a large umbrella diagnosis where you have neuropathic and myopathic. The neuropathy can be UMN conditions like Friedreich's ataxia, cerebral palsy. LMN, basically, we'll be talking on spinal muscular atrophy, poliomyelitis. Then myopathic conditions like Duchenne muscular, Becker's. This in a broad terminology, neuromuscular scoliosis encompasses all of these things. There are syndromic scoliosis, which is seen in neurofibromatosis, Marfan syndrome. Those things don't fall under the criteria of neuromuscular scoliosis. So what is the incidence of scoliosis? That's an interesting chart, because in spinal muscular atrophy, they give the percentage as 67%, which is actually misleading, because they've taken all four SMAs in this. If you take SMA 1 and 2 alone, the incidence is 100%. All these children will get scoliosis at some point in their life. And before we go into it, there's a certain language of scoliosis, because these are certain words which you will hear thrown around quite frequently when you're dealing with patients with scoliosis. One is strategic vertebrae, what is vertebral rotation, what is decompensation, what is the curve angle, and what do we really mean by progression, what is flexibility, and what really is pelvic obliquity. Strategic vertebrae, there are many, but basically there are three. The first one is the apical vertebra. Whenever you see a scoliosis, this is not a neuromuscular scoliosis, it's a straightforward allodus case. When you have a scoliotic X-ray, the first line you draw is a central sacral vertical line. You draw a perpendicular from the middle of the sacrum. The vertebra that is farthest from this line is called the apical vertebra. And that is the vertebra that is going to be maximally rotated and farthest away from the midline. That is the apical vertebra, and that is the apex of the curve. That is perhaps the vertebra that is keying this curve to progress. That's the most deformed vertebra. And then we have the end vertebrae. End vertebrae are those vertebrae which are tilted maximally into the curve. For example, in this right thoracic curve, the same X-ray as previous, in this right thoracic curve, the two vertebrae that are tilted maximally into the curve are called the end vertebrae. They become important because the end vertebrae are the places where you measure the curve. And then there's a thing called a neutral vertebrae, because when you look at a spine X-ray, the two pedicles should be looking at you like eyes on a face. In a rotated spine, you don't see the pedicles end on. And if you're seeing the pedicles end on in the middle of the curve, that is a neutral vertebra. That tells you where the proximal curve has ended and the distal curve is beginning. So that is a neutral vertebra. And coming to rotation, rotation is the key thing in scoliosis. It is not just a coronal plane deformity. It is the rotation of the vertebra that causes scoliosis. And if you are interested in civil engineering, there's a theorem by Euler's buckling of long column theory. When a long column fails under load or gravity, it doesn't just bend or burst. It twists and buckles. That is the same thing that happens to the spine. So rotation is the key element in scoliosis. So this is how you grade the rotation, the Nash-Mo method, in which the neutral vertebra will be, both pedicles will be looking straight at you. And as the vertebra rotates, one pedicle sort of tends to disappear. A good example in a SMA case, SMA scoliosis, you can see the AP and the lateral. If you see the lateral actually looks like an AP on the other side, because both the vertebrae, both the pedicles are looking at you in the lateral. That is the amount of rotation you tend to encounter in these cases. So this can be grossly rotated. And there is a word called decompensation. Normally, the head has to, if you draw a plumb line or drop a plumb line from the posterior aspect of the head, it has to bisect the body and go into the natal cleft. So if that is not there, that means the head is decompensated. It is not just the decompensation of the head, because you can have a truncal decompensation also, which is present only in severe curves, and most neuromuscular scoliosis do fall under that curve where there is truncal decompensation as well. And whenever we speak of scoliosis, everyone starts speaking about curve angle. This is how you measure the curve. There are innumerable fallacies in measuring a curve angle. We'll come to that. This is how we measure a curve angle. First, you find out the end vertebrae. The vertebrae, those are tilted maximally into the curve. You draw perpendiculars to that, perpendicular to the end plates, and you measure the angle in between. So that gives you the curve angle. I have the next slide is an X-ray from a picture from the textbook, which shows 4 spines. And all 4 will show different curve angles if you measure it that way. But they are the same patient. They are the same X-ray. We are trying to assess a 3-dimensional deformity with a 2-dimensional film. So that is a basic fallacy of a curve angle. But the problem is we don't have anything to substitute it with. So that is why we still use it. It is easily reproducible. You can communicate quite easily. And on every follow-up, you can get an X-ray. Well, you can't get a CT looking down the child every time the child comes in for follow-up. So that is the reason why we still use the curve angle, and all criteria for surgery, conservative, everything is based, severity. They're all based on curve angle, even though there are inherent fallacies in this curve. So low curve angle of say 35 or 40 does not necessarily mean that the child is not having a deformity, because of the inherent nature of measuring the curve angle on a 2D film. While you are supposed to do it on Suppose you're dealing with a three-dimensional deformity. And the progression of curves are quite similar, or they follow the pattern in neuromuscular and adolescent diabetic. They usually progress as the child grows. And when there is a prepubertal growth spurt, or when the child attains at peak height velocity, that is when the curve maximally increases. From between 2 visits of 6 months apart, if there is an increase of 5 to 10 degrees in the curve angle, you say that the curve is progressing. The rate can vary from 5.2 to 40 degrees, depending on the etiology, depending on the growth pattern. But if it is progressing by 5 to 10 degrees, that means it is progression. The reason I think they kept as 5 is because the interobservable difference in curve angle measurement is 5. So it is safer to take as a 10-degree difference in curve angle. Then we talk about flexibility, because as surgeons who are trying to tackle this on table, this is a key thing for us. Because if it is a flexible curve, even if it is a 90-degree curve, we don't lose sleep the previous night. But if it is a rigid curve, it's an entirely different ballgame. Child has to undergo osteotomies and blood loss will be much higher. So to assess flexibility, the commonest thing which we do is a bending. All X-rays in scoliosis are erect weight-bearing X-rays. If the child is not ambulant, you get a sitting X-ray. If the child is ambulant or is able to stand, you have to get a standing long film X-ray. There are no supine X-rays in scoliosis. You cannot assess the deformity in a supine film, either a sitting or a standing X-ray. Another option to assess the flexibility, you can take a supine side bending film. This is a standing X-ray of a curve, which shows a thoracolumbar curve in the AP, which is almost around 85 to 90 degrees. And these are the bending films. You take a right convex and a concave bending film. You ask the child to bend as much as possible, and then you shoot the X-ray. And this one, you can see that it is fairly stiff curve because it is not straightening out. The second curve you measure on the bending film does not show much of a correction. If the correction is less than 25%, you can label it as a stiff curve. The reason why you take the concave bending is that there is always 3 curves in a single film. Even if there is one large curve, there can be a curve above and below, which can manifest itself on the bending film. So if you neglect that curve and you correct the main curve alone, and if the other curves are significant, the child can recompensate postoperatively. That's the reason for the bending film. Another option is to get a fulcrum film or traction film. A fulcrum film is nothing but you keep a pillow under the rib hump and you shoot a lateral. That's a fulcrum film or a traction film. It is self-flexible. These are the ways where you assess flexibilities of it. Now we come to pelvic obliquity, because in neuromuscular, that's a thing that we are worried about. Pelvic obliquity can be because of 3 things. You can have suprapelvic causes for pelvic obliquity, pelvic causes which are rare, congenital aplasias, Renshaw's classification, secular agenesis, and all these things. And infrapelvic causes because of bilateral hip deformities. So in a suprapelvic cause, if there is a fixed scoliosis above the spine, you can produce a pelvic obliquity. And if there is a bilateral hip deformity, which is like a windswept pattern, one side adduction, one side abduction, with or without subluxation or dislocation. Even without dislocation, you can have a pelvic obliquity. So the pelvic can be very often. In neuromuscular scoliosis, especially in spinomuscular dystrophies, the pelvic obliquity, even in the presence of dislocated hips or deformities in the lower limb, the main reason for that, or the thing to tackle, is the spine. It is not the hips. A good example of a case of SMA scoliosis, one of our children. You can see the hip on the other side is actually subluxed out, or even frankly dislocated if you are a bit more pessimistic. It is subluxated out because of the stiff curve or a stiff C shape. Like we said before, the development of scoliosis is almost universal in type 1 and 2. And in 2, it occurs by the age of around 2 to 3. And most of the time it progresses. It is rare to find a curve that does not progress. The degree of progression, the dramatic way by which it progresses can vary from person to person, depending on the sitting status, the pelvic obliquity, all this. But it usually progresses. And the pattern is a sweeping C-shaped curve in vast majority. And there is always a collapsing kyphosis because of the utter lack of muscle power. They have a collapsing kyphosis. And the severity of the curve is much less in ambulators. In certain neuromuscular conditions where the child is ambulant, the pattern can resemble an adolescent diabetic scoliosis, which is fairly benign compared to the curve in juvenile compared to the curve in neuromuscular scoliosis. So then what is the natural history? All curves progress. And do they progress after skeletal maturity? Yes, they do progress after skeletal maturity in neuromuscular. If a curve is more than 50 at skeletal maturity, they tend to progress at 1.4 degrees per year. That is the rate of progression. And which all curves are aggressive? If the onset of the curve is early, say the child is 3 years and he has already got a curve, that means it is going to be an aggressive curve. And at 10 years, if the curve angle is 30 degrees, along with the hip subluxation, which indirectly means that there is a fixed pelvic obliquity. It is not the hip subluxation that is producing or worsening the curve. It is the pelvic obliquity that is driving the curve. Hip subluxation is because of the pelvic obliquity. So an early onset, curve of 30 at 10 years, and pelvic obliquity. These are the things that tell you that it is going to be an aggressive curve, that it is quite likely to progress rapidly. And the motor function score, like we said, if the child is ambulant, the chance of progression and having a severe curve is quite less. And even if they do have a curve, like I said before, it tends to resemble an idiopathic curve and not a neuromuscular curve. The higher the GFMC level, the larger the curve is going to be, and the difficult the surgery is going to be. So what causes scoliosis? It can be muscle imbalance, can be total lack of trunk support, which produces a buckling collapse, or it can even be osteoporosis. Most of these children are porotic, and wedging of this vertebra can occur, producing or worsening the pre-existing scoliosis. And how do you evaluate when a child comes for scoliosis? We need direct X-rays or sitting X-rays. We always need pelvic X-rays. And do we need MRIs? Ideally, no. But if it is worsening quite dramatically, you want to rule out other things like TRE or syringe, whatever, or a diastrophy, some other cause along with it. Even nobody says there can't be two pathologies in the same child. So you want an MRI. You don't routinely need an MRI, but you want an MRI if it is a dramatic progression. And how frequently do you evaluate? It depends on the peak height velocity. If the child is in the phase of the growth spurt, you call them quite frequently, maybe around 6 months. Otherwise, yearly follow-up is sufficient for screening for scoliosis. Clinically, what are things you look for? Clinically, we look at the GFMCS levels, look for sitting balance. Is the child able to sit properly, comfortably, and is the child tolerating the sitting position? That's a key thing. Is the child able to tolerate that position? And cognition of the child. Does the child have head control? That is key when you're correcting. Because after the spine becomes straight, the head is flopping around. There's no fun in it. You look at the skin, because most of these children, like the X-ray I showed previously, have a large, deep skin crease, which can even ulcerate or macerate. So that is an issue. So skin has to be seen, and always assess the flexibility. In a younger child, you can just lift up the child, and if the curve is disappearing, the curve is flexible. That does not mean the child does not have a scoliosis or it does not need surgery. No, that does not mean that. It only means that if the child is too small or if you want to withhold the surgery, you can hold the child in a modified wheelchair or a soft orthosis, which the child is likely to tolerate. No children will tolerate our TLSO, which is made of alpha-10. It's quite difficult and perhaps a bit cruel also. The soft orthosis will be well tolerated and it can be held for some time, at least till the child grows up and is fit enough to undergo it. So what about bracing? Bracing is unlikely to change the natural history of scoliosis. But like we said before, we can hold off surgery in the very young. And ideally, you should have a brace that opens like a book, and which has got the option of attachment of a leg component if necessary. And why should we operate, or what is the surgical goal? A stable erect spine, balance of the pelvis. And main thing is to prevent progression. All the rest is secondary. We don't want the curve to progress. And after the surgery, improvements are usually seen in caregiver scores mostly, which actually matters more than anything else. The caregivers are usually better judges of the results of any treatment. And caregiver scores usually improve after surgical correction. Social interaction of the child improves, the hand use improves, sitting tolerance improves. Regarding the respiratory and GIT functions, which we usually say as key things in the child's life, it's quite debatable whether they really improve or not. They may not improve, to be honest. Respiratory function, the lung volume maturity occurs at around 8 years. After that, there is no increase in lung volume. The posture of the child might increase, can help with physio, can prevent aspirations, can prevent a reflux. But do these functions improve? That's debatable. So, whom to offer surgery? If there is a progressive stiff coronal deformity of more than 50 degrees or a sagittal deformity of more than 70, we can offer surgery, especially if there is a complaint of pain with poor sitting balance. This is the child whom we want to offer surgery. And more importantly, neuromuscular, whom not to offer surgery. If it is a minor deformity and it is not progressing, wait and watch. Wait for some time. If it is a flexible deformity and it can be managed in a soft brace or a wheelchair modification, wait on that. If the child is too small with low BMI, your chance of wound dehiscence, postoperative complications are pretty high. So that is a red flag there. And if the child has got frequent chest issues, I usually ask how many times the child has got admitted for chest complaints in the last 3 months. If the answer is 1, I'm a bit hesitant. Always ask for hospital admissions for chest infections. And medical issues, because not especially in other neuromuscular conditions where you can have myopathies like Duchenne's, etc. You have to get a clearance from cardiology, etc. And these children can have infection, either urinary or chest infection. So those things have to be looked at. And perhaps the most important is the presence of social support. If you operate the child and you send him home, how comfortable is he going to be in his milieu? Or how his parents are dealing with this condition? How much support he has got? That is quite crucial before you embark on a surgery in neuromuscular scoliosis. And like we said, sometimes some things are not alterable. This is not our X-ray, it's from the net. You can see the really collapsed lung field on that X-ray. This is not going to improve in this child. So in this situation, what we have done, not quite frequently, but once or twice, what we have done is we put the child on a traction, preoperatively halo traction. You try to pull out the spine, and then we repeat the PFT. If there is an improvement, we proceed with the correction. If there is no improvement, we can't do much in these particular situations. So preoperative assessments become important, mainly the nutrition of the child, the basic blood parameters, albumin levels, transferrin, all these things are important. We want a respiratory consult for PFT. And 40% of expected vital capacity, if it is less than that, that is considered to be critical in PFT. Most of these children cannot cooperate with the PFT properly. Either they don't understand or they are too young. In those situations, we do a room air IVG or get a sleeping saturation. Not as good as a PFT, but we have some idea what is happening. A full blood panel is mandatory. And neuromuscular surgeries, somehow they tend to bleed a bit more than adolescent scoliosis. So we always arrange for an autologous hemodilution, ANH. Before the surgery, we inform the blood bank. If the child has got adequate hematocrit and weight, they come pre-bleed the child in theater after induction of anesthesia. Pre-bleed the child, and we use that blood 3 times the whatever blood is removed, 3 times fluid is replaced. So during the surgery, we're not losing child's blood, and we can somehow prevent transfusion. And the other thing is a cell saver. The cell saver is a double-edged thing. First of all, it's expensive. Even the tubings alone come to around 30,000 rupees, which have to reuse. Second issue with the cell saver is when you are transfusing the blood again, you're not getting any clotting factors. It is some red fluid that is going in, but it can be a vicious cycle. If there is significant bleeding, like more than 2 times allowed blood loss or something like that, and you're using a cell saver, you might end up in a coagulopathy. So that is a double-edged thing, cell saver. One thing that makes your life easy to a certain extent is a preoperative traction. We have our own device, which it is sort of indigenously made. We put a halo for the child and we put the child on traction. And we get an X-ray after 2 weeks. If we see some improvement in the curve, we continue the traction for up to 6 weeks. If you don't see any improvement, there's no point in continuing the traction. we take the child for surgery. And on table, what are the things which we do? First of all, there are no anterior surgeries in this. The child won't tolerate an anterior surgery. The child will end up on a respiratory postoperative. So it's always a posterior surgery, no matter how severe or where the curve is. And if it is stiff curve, which is not flexible, you have to do multiple osteotomies. That is called a Ponte osteotomy. I think I have a slide on it. And you want maximum implant density in these patients for two reasons. One, you have to get a segmental correction, which is gradual and harmonic. And another main reason is that most of the time these children are porotic, so that you may not have much purchase with the pedicle scope. Like one of the things our colleagues used to say is that scoliosis is caused by titanium deficiency. The moment you put in titanium in the spine, the scoliosis disappears. So that is the implant density we are looking at. And the key question is whether to extend to the pelvis or not. That is a crucial question for the child and the surgeon. Extension to the pelvis means a longer surgery, more blood loss. But in certain situations of significant pelvic obesity, you have to fuse into the pelvis. If you fuse into the pelvis in an ambulating child, the child will become a non-ambulator soon. So it is reserved for non-ambulant children with significant pelvic obesity, fusion into the pelvis. It has to be an in and out surgery because infection rates are reportedly higher in neuromuscular scoliosis. So it has to be a fast surgery, and you can give intraoperative traction. The same traction, the same halo you apply preoperatively is continued on table, and always use an IONM. You don't want a worsening of neurology. This is how we set up an intraoperative traction. 50% of the body weight is divided between the two lower limbs, and you apply a pin through the femur and you apply a femoral traction, and 1/3 of the counterweight is applied to the head of the patient. So that's how we give an intraoperative traction. And this is how you do a Ponte osteotomy, because this is the only release you can do in neuromuscular. You cannot go anteriorly and release the discs. You can't do a thoracotomy. You can't do a thoracocrineal lumbotomy. The only thing you can do is you can take out the posterior facets, the superior facets and the inferior facets, and make the spine a bit flexible. That's the only osteotomy you can do in stiff curve from the posterior rest. So then the question is growing rods. In early onset scoliosis, which is idiopathic in nature, growing rods have a role, but they do not have much of a role in neuromuscular, mainly for the reason that the growing rods that are available here require frequent distractions. Probably every 6 months you take the child back and you distract. Magnetic rods are available, but they are quite expensive. They're called magic rods. Magnetic lengthening is available, quite expensive. I have no experience with magnetic rods. Growing rods with distraction, we have not tried in neuromuscular at all, because taking the child to theater once is enough of a headache. I don't want to face that every 6 months. No. So early onset scoliosis, we do growing rods, but this is the indication in for growing rods in neuromuscular. Age less than 11, with a stable medical condition. It is not a progressive condition, and too tiny child. T1 to T12 is only 20%. So you can consider growing rod. But most of the time in neuromuscular, you want a sure shot answer, one shot solution. So you go for a definitive fusion because they cannot tolerate multiple disorders. Ideally, it has to be a larger child. Yes, that is there. When to fuse to the pelvis. If the child is an independent sitter or a balanced spine, you don't have to fuse to the pelvis. If the curve is more dorsalumbar and less lumbar, you don't have to fuse to the pelvis. If the pelvic obliquity is low, say less than 10 degrees of pelvic obliquity, you don't have to fuse to the pelvis. If the sagittal profile is normal, then you don't have to fuse to the pelvis. If the child is an ambulator, you don't have to fuse to the pelvis. Neuromuscular scoliosis has got a much higher rate of complication than adolescent baby scoliosis, which goes up to 30%. Mainly because of the duration, the blood loss, respiratory issues, neurological issues. Chance of infection is high. The child is usually osteoporotic. And there's a peculiar entity called a PJK, or a proximal junctional kyphosis, where you stop your fusion. Say if you accidentally stop at 4 or 5, D4 or D5, the vertebrae above that will go into kyphosis. It will just drop down. That is called proximal junctional kyphosis. So to prevent that, what we do is we keep the midline intact and do not disturb the facet above, and never stop at lower thoracic in neuromuscular. Always go up to D2. The moment you reach D3 or D2, the chance of PJK is much lesser. This is an interesting guideline which I found, which is called the Dutch guideline, and one of the contributors is Dr. Marinus de Cloer. He had the opportunity to associate with him in a short period. And according to their guidelines, all children with SMA2 will develop scoliosis at around 4 years. 80% of them are lower thoracic. Bracing does not prevent progression. And a lower limb surgery to prevent a spine deformity doesn't help. So there is no point in relocating a dislocated hip or releasing an adduction contraction of the hip to correct the pelvic obliquity which is caused by the spine. So there is no role for a lower limb surgery. And the force visual capacity of less than 40% is severe impairment. You have to be cautious in children below that. And when possible, avoid the pelvis. Use a segmental intervention. Avoid an anterior surgery. Mobilize them early. Use intraoperative monitoring. There is definite improvement in activities of daily living. If there is a post-op head tilt, don't go in again and twist in the cervical spine. Consider a wheelchair modification. And hip subluxations are quite common in SMA, like we said before. They do not require surgical intervention. That is true about contractures. The knee contracture producing flexion deformity in a sitting child does not really warrant a surgical intervention. They are medically and surgically challenging cases, socially also. Pre-op optimization, counseling, multiple anchor points in the spine, and posterior surgery. That is the key in neuromuscular. Thank you.
Thank you, Dr. Ashok, for taking us into this world of scoliosis. There are two questions from Dr. Partha Ray. One is, did you say that ambulant patients have less scoliosis than patients who are not bed-bound? If so, is that related to SMN dosage and copy number variants of SMN2, etc.? I think I'll answer that question. It is not related to it cannot be related to the SMN dosage and copy number variants. It depends upon the amount of weakness a patient has. Is there a genetic subtype of scoliosis in SMA subtypes? Any studies in your series? We have not actually taken an audit of our cases yet. But the first line, did you say that ambulant patients have less scoliosis than patients who are not bed-bound? Will you answer that, Dr. Ashok?
Yes, ambulant patients have less severity of scoliosis because in ambulant patients, the extent of pelvic obliquity seen is quite less. They do develop scoliosis, but if the child is ambulant, the chance of it resembling a simple idiopathic scoliosis is higher. It does not take the form of a malignant curve, which we see in typical cases. If the child is ambulant, then the curve is likely to be less. That is a general rule.
So the next question, if according to civil engineering, load determines the degree of severity of scoliosis, how do SMA type 1 and 2 have more scoliosis as they do not ambulate, while SMA3 who walks and bears load has less of scoliosis? I think it is well explained, though, because SMA 1 and 2 have more weakness and therefore there is more scoliosis. Is that right, Dr. Ashok?
Yeah, yes, madam. That seems to be the reason behind that. Even when a child is sitting, the funny thing is there are no models for scoliosis. Forget neuromuscular. There are no animal models for scoliosis. The closest we have is the zebrafish model, because there is no way we can replicate a spinal deformity and its and gravity's influence on it. Because in a zebrafish, because they swim against the current, we believe that that sort of simulates the effect of gravity, and all studies are on zebrafish. And one of these theories regarding the Euler's hypothesis is by a guy called Dixon. The Dixon's group, they believe that scoliosis is a mechanical thing. And they bring forth the concept of three maturities. One is a postural maturity and a skeletal maturity. So if the postural maturity is delayed and the child has skeletal maturity, they go into lower doses. So that is one of the reasons why we see all idiopathic scoliosis, predominantly 90% of them are females. So they attain skeletal maturity faster, but they lack in postural maturity. So before the normal kyphosis
thank you, Dr. Ashok.
Yeah,
we are running short of time. Shall we stop? Will you stop sharing? Dr. Ashmi, please start sharing your slide. Please stop sharing, Dr. Ashok. Stop sharing. So, Dr. Ishmael, present the case fast. Slideshow.
Thank you, ma'am. I'll be discussing the case of a child with congenital muscular dystrophy presented as young stroke. He was a 19-year-old boy who was a case of congenital muscular dystrophy and who had presented with recent young stroke with a hemiplegia, a right parietal mid-cerebral artery tertiary infarct also. And coming to the history, he had developmental delay since birth, and he also had defective vision, which was noticed at 2.5 years. And subsequently, bilateral high myopia, glaucoma, and cataract also were detected in both eyes. And he had speech delay with speech onset at 3 years of age with a slow progression to phrases by 7 years. And at 19 years, he could answer when questioned in barely 3-word sentences only. And spontaneous speech was limited to voicing needs and uttering protests. And he could comprehend simple one-step commands, but he was completely lacking in abstract thinking, mathematical ability, writing, reading, and reasoning. He could walk, and from early infancy, the mother noted weakness of all 4 limbs with a proximal emphasis, and his creatine phosphokinase values range from 300 to 5,000 international units per liter with a normal echocardiogram. His best achieved motor milestones was walking with support, and MRI brain had shown revealed cobblestone lissencephaly in the cerebrum, involving both bilateral frontal lobes and left occipital lobe. And there was also disorganized cerebellar folia with a small cystic area and an abnormally flattened cones and ventricular enlargement. This is the T1 axis section at the level of basal ganglia showing cobblestone lissencephaly. That is, there is reduction in normal sulcation and there is some bumpy or pebbly appearance of the surface of the cerebrum as seen, which can be seen in bilateral frontal lobe and the left occipital lobe. And we could, in the suggested section, we could also observe the cerebellar cyst and the cerebellar hypoplasia and the thinning of the pons and ventricular enlargement also can be observed. And with this constellation of symptoms and findings, we have thought of congenital muscular dystrophy with the eye brain involvement, and he was. And he was born out of non-consanguineous marriage with the 2 siblings. One was normal, and the eldest sister had remained bedridden from the age of 2 and died of unknown cause at 8 years and 6 months. And there was no other affected family members. And at 19 years of age, he had presented with stroke. And the setting of this muscle disease, cardioembolic cause was suspected. And an echocardiography revealed dilated left ventricle with severe global hypokinesia and an estimated ejection fraction of merely 30%, which is suggestive of dilated cardiomyopathy. And clinical exome sequencing had come positive for a pathogenic variant of POMGNT1 mutation, which was an autosomal recessive gene present in homozygous, which is usually associated with congenital muscular dystrophy, specifically dystrophic leukodystrophy type A3 with brain and eye anomalies. And from this take-home message being his cardiac involvement could have been diagnosed earlier and cardioprotective drugs given so that his left ventricular dysfunction could not have become so irreversible. And he could have been put on cardioprotective drugs even before the myocardium got affected. Thank you.
Please stop sharing. Dr. Rakesh, shall I go on to the short presentation on management?
Yeah, please, madam. So Dr. Ayub, madam, will be telling us about the early detection of cardiomyopathy. This is a very, very important topic in patients of neuromuscular diseases. Yes, madam.
Thank you very much for the opportunity. I think I'll give an overview so that you can all go back and read because time is running short. So cardiac involvement in neuromuscular diseases can be either conduction disorders or myocardial disease. And myocardial disease can be dilated cardiomyopathy or hypertrophic cardiomyopathy. I will not go into the details, but I enumerate some of the diseases that have cardiac involvement. And the disease that has been best studied is Duchenne muscular dystrophy, where you can get cardiomyopathy, which is very, very common. Conduction disorders are also seen in Duchenne muscular dystrophy. Steiner diseases, myotonic dystrophy, where you have arrhythmias, Emery Dreifuss muscular dystrophy of arrhythmias, limb-girdle muscular dystrophy 1B, where lamin A and C are affected, as arrhythmias and cardiomyopathy associated. Kearns-Sayre syndrome is the mitochondrial cytopathy, where you have predominantly arrhythmias, Friedreich's ataxia, hypertrophy, cardiomyopathy, and atrial fibrillation. Then other neuromuscular disease and LGMD21, which is gluten-related, where you have cardiomyopathy, facioscapulohumeral muscular dystrophy, you have SVT, supraventricular tachycardia, and asymptomatic right bundle branch block. In all these diseases, we are so excited to make a diagnosis. We forget that the cardiomyopathy could be associated. Today, with the better supportive care and longevity of these children, the issue of cardiomyopathy becomes important. Like the case that we have already presented, the cardiomyopathy can be complicated by thrombus and even cardioembolic stroke, as we have seen. Now, Anderson-Tarvel syndrome, as you know, is associated with arrhythmias, ventricular arrhythmias, bidirectional ventricular tachycardia seen in this syndrome in the absence of digoxin toxicity. Mitochondrial myopathies, MERF, MELAS, are both associated with cardiomyopathy and ventricular and atrial arrhythmias. Barth syndrome is another mitochondrial cytopathy associated cardiomyopathy or arrhythmias. Pompe's disease, you could have hypertrophic cardiomyopathy or arrhythmias. The other congenital myopathies with the heart involvement are Nemelin, central core myopathy, congenital fiber type disproportion, and myofibrillar myopathy. So once you make a diagnosis, we are supposed to monitor for the involvement of the heart. These are the congenital muscular dystrophies. Bethlehem congenital muscular dystrophy, then you could get progressive left ventricular dysfunction. Unlike Ulrich, where heart involvement is less common. Myosin deficiency, Fukuyama congenital muscular dystrophy, and the dystroglycanopathies. The case presented was PONGNT1. And these children could have dilated cardiomyopathy, mitral valve regurgitation, minor conduction movements. So why the heart is important? Duchenne muscular, the disease that has been studied is Duchenne muscular dystrophy. Why the heart is important? Because significant advances in respiratory care is unmasking cardiomyopathy as a leading cause of death in DMD, because otherwise these children would have died without steroids, without the definitive treatment. The longevity would not have been so much. You look at this picture which shows that in 1960s, death was by around just after 10 years. In the 70s, 80s and 90s, it was towards 20 years. And beyond 1990s, with ventilatory support and steroids, the mortality has decreased and the survival is up to nearly 30 years. So this issue of cardiac involvement becomes more important. And severe heart failure occurs in DMD patients from the early teens and is very common in patients above 18 years of age. Progression of cardiomyopathy, there is a preclinical stage, a subclinical stage, which occurs before 10 years of age. From 10 to 18 years, there is a clinical stage of disease where you have subendocardial fibrosis, which can be detected by special tests, which we'll come to. And then beyond 20 years, there's detectable cardiac involvement, there's systolic dysfunction, dilated cardiomyopathy, arrhythmias. And how is cardiomyopathy diagnosed? The history and physical examination will help you. There'll be dyspnea on exertion. The ABP will be elevated, there'll be edema. The ECG may show changes which will be shown later. Echocardiogram is useful. Cardiac MRI, Holter, and the loop recorder may be used in children who have less frequent arrhythmias. The brain natriuretic peptide and NT-proBNP are useful markers, and the troponins. The signs and symptoms of cardiac dysfunction DMD, cardiac symptoms typically appear late because boys with Duchenne are wheelchair bound and physically inactive, so they cannot complain of dyspnea on exertion. So symptoms of palpitation, dyspnea, and paroxysmal nocturnal dyspnea. There may be elevated heart rate, respiratory rate, arrhythmias, hypotension, cardiomegaly, murmurs of regurgitation. So this is a typical EEG of a Duchenne muscular dystrophy, where you find that the RS ratio is more than 1 in lead B1. The R wave is higher. There could even be a right bundle branch block with a RS R' pattern. And Q wave is seen in the lateral leads, lead 1, 2, and ABL and V5, V6. So all this seen in Duchenne muscular dystrophy. Ambulatory Holter monitoring is useful. In a study of 150 boys, 11% had arrhythmias and 25% of those with cardiomyopathy had arrhythmias. So it is not only an echocardiogram that is needed, ambulatory Holter monitoring is also needed in children with Duchenne muscular dystrophy. look for arrhythmias. The echocardiogram should be done at diagnosis or at least by age 6. Because we are so excited to make a diagnosis of a muscular dystrophy, we forget about the heart. So even at diagnosis, we have to get a baseline echocardiogram at least by 6 years. And subsequent echo studies should be done every 1 to 2 years. And after 10 years of age, it should be an annual echocardiogram. So this is a typical 4-chamber view where you find the LV is dilated. And here again, you can find that the LV, this is the LV, this black portion is the LV. And the undulations here shows the diastole and the systole. In the normal heart, you find that there are more bumps where the volume of the left ventricle becomes lesser during systole and more during diastole. But here it is merely a straight line is showing dysfunction. So the cardiac MRI, what you look for is a late gadolinium enhancement. These arrows show the late gadolinium enhancement on the lateral wall of the heart. And this is a septum where you don't find the gadolinium enhancement. The gadolinium enhancement is seen in the lateral wall. This is seen when there is fibrosis, and this is an early indicator of heart involvement in children with Duchenne muscular dystrophy. So gadolinium enhanced cardiac MRI is useful in early detection. So heart failure, you could say that a patient has heart failure when the ejection fraction is reduced. Normally the ejection fraction is around 66%. And heart failure is classified as those with reduced ejection fraction when the ejection fraction is less than 40%, with preserved ejection fraction, the ejection fraction is more than 50%, with mildly reduced ejection fraction when it is between 40 and 50%. So when you get the echo report, you can know how much the heart is involved. A gradual fall in the ejection fraction with a ventricular dilatation is a red flag sign, as you do serial echocardiogram. And the earliest indicator is a global longitudinal strain on strain rate imaging during echocardiogram. Management of heart failure, there are 4 pillars. The drugs that act on the renin-angiotensin-aldosterone system, which are the ACE inhibitors, the ARBs, and the ARNI. ARNI is angiotensin receptor neprilysin inhibitor, which is preferred to ACE inhibitors or angiotensin receptor blocker. And ARNI is valsartan with a drug called sacubitril, which is a neprilysin inhibitor. So you don't give all 3 together. It is either of ACE inhibitor, ARB, or ARNI. And ARNI is preferred. And beta blockers, the 4 pillars are the drugs that act on the renin-angiotensin-aldosterone system, the beta blockers, the mineralocorticoid receptor antagonists, phenolactone, eplerenone, and the SGLT2 inhibitors, the empagliflozin and empagliflozin. In children, empagliflozin, which is normally used as an anti-diabetic drug, is has not been tried in cardiac failure. So the 3 drugs that can be used are these ACE inhibitor, ARB or ARNI, beta blocker, or the mineralocorticoid receptor antagonist. And the ARNI has been FDA approved for children beyond 6 months age in 2019. Normally, you begin with one of the RAS inhibitor, then add beta blocker, and then the mineralocorticoid receptor antagonist. That's what is normally done. Digoxin and diuretics is used in symptomatic patients. This shows the 4 pillars: the ARNI or ACE inhibitors, beta blocker, SGLT2 inhibitor, and the mineralocorticoid receptor. And these are 4 pillars for the treatment of heart failure. And if this fails, medical therapy fails, you have the intracardiac device that we will come to. So ACE inhibitors or ARBs has now become the standard of care in DMD population. This is not only when heart failure is settled, this is used in prophylaxis also. It is now, that is in 2014, the National Heart, Lung and Blood Institute Working Group has stated that ACE inhibitors or ARB has to be initiated in DMD by at least 10 years of age. This is prophylaxis. And one could consider earlier use also. ARNIs, that's angiotensin receptor neprilysin inhibitor, sacubitril valsartan combination is preferred. And use of beta blockers, it's a common practice to begin after ACE inhibitors or ARNI or ARB. How to initiate ACE inhibitors, ARB or ARNI? You check blood urea, serum creatinine, potassium during initiation and during follow-up. and start with a small dose. Enalapril is started with 2.5 milligram BD, valsartan 40 milligram BD, and Arni 25 milligram BD. There are Arni tablets available at 25, 50, 100, and 200. Gradually step up the dose to maximally tolerated dose. Enalapril 10 milligram BD, valsartan 320 milligram daily, or Arni 200 milligram BID. The minimum systolic blood pressure of 100 millimeter of mercury is needed. Reduce the dose of systolic blood pressure falls below 100 millimeter. The dosing of enalapril in a child has been, the milligram per kilogram dose has been given as 0.4 milligram per kilogram BD. That's an ACE inhibitor. Arni, the dose is 3.1 milligram per kilogram given twice daily. So ACE inhibitors should not be given along with Arni. So if a patient is on an ACE inhibitor and you want to start Arni, there should be a gap after stopping ACE inhibitor of 36 hours. But ARB can be immediately changed to angiotensin receptor neprilysin inhibitor. So perindopril is the ACE inhibitor that has been used in studies. Though we use enalapril, which is cheaper and available in government outlets. Perindopril in this study, this is the Kaplan-Meier curve, which shows that the first group who had received perindopril has got a better cardiac function than the group allocated to placebo. So this is the scenario where there so many studies have been done on RB, sacubitril, valsartan combination in children with heart failure, and it has been found to be superior to ARBs and ACE inhibitors. So beta blocker, carvedilol is the drug that has been used. Not all beta blockers can be used. You cannot use atenolol or propranolol. Only cardio-selective beta blockers are used. Carvedilol, bisoprolol, and metoprolol are used. And one study has assessed its use in 22 patients dilated cardiomyopathy with significant improvements. How to initiate beta blockers? Usually initiate after the RAS drugs acting on the RAS mechanism. Start with small dose. Metoprolol succinate is given once daily, 25 milligram. Or you start bisoprolol 1.25 milligram or carvedilol 3.125 milligram. Gradually step up the dose to maximum of 200 milligram or 10 milligram bisoprolol or 25 milligram BD of carvedilol. The minimum systolic blood pressure should be 100 millimeter. Heart rate should be above 65. Avoid if the patient has AV block or a PR interval of more than 200 milliseconds. Should be started only in patients with no congestion in the lung fields or congestion in the systemic circulation, as evidenced by high JVP or edema, meaning to say this beta blocker is not given once the heart failure is set in. So eplerenone is the drug that acts on it's an aldosterone receptor antagonist. This is a study which shows that the myocardial strain is less in children given the eplerenone compared to placebo, and the heart and the LV ejection fraction is better in giving eplerenone compared to placebo. And glucocorticoid use in DMD, glucocorticoid use now it has been shown to have effect on the heart. The overall survival is more in children given glucocorticoid. This is the Kaplan-Meier curve compared to children with no steroid therapy. This is the freedom from cardiomyopathies also. The upper curve show is the dose on steroid, and the patients on placebo have shown this is freedom from cardiomyopathy. They have less freedom from cardiomyopathy. So steroids also protect from cardiac involvement. Cardiac management of DMD and BMD. It is in Duchenne muscular dystrophy that ACE inhibitors and ARBs have been found to be beneficial. Studies have not been done in Becker muscular dystrophy. Follow-up, ECG and transthoracic echocardiography should be done every 5 years in BMD, and in DMD every 2 years, and after 10 years of age, once a year. In the female who is asymptomatic, that's a mother who's a carrier, also needs ECG and transthoracic echocardiogram to look for cardiac involvement. The emerging cardiac treatments are dystrophic gene therapy, implantable cardioverter defibrillators, gene editing, exon skipping, Polaxamer 188, which is synthetic, phosphodiesterase inhibition, cardiac resynchronization therapy, heart transplantation, mechanical circulatory support, cardiac stem cell therapy. This is the implantable cardioverter defibrillator. This should be in place as primary prevention of cardiac failure, primary prevention of sudden cardiac death when the ejection fraction is less than 35%. Once a patient has had ventricular fibrillation, the implantable cardioverter defibrillator is indicated. Once he has one ventricular fibrillation from which he has been salvaged. And if the ejection fraction is less than 35%, this implantable ICD should be in place. The cardiac resynchronization therapy is a procedure to implant a pacemaker in the chest. This is different from the normal pacemaker in that this paces both the ventricles in a synchronized and efficient manner. Ventricular assist device is a destination therapy for end-stage heart failure, and there are reports of use in patients with end-stage heart failure. 3 patients in Italy, 2 in US. This may come up in a big way later. So heart transplantation. Children with muscular dystrophy have undergone heart transplantation, and there's a study that has compared children with muscular dystrophy who had transplantation compared to controls with other diseases who had transplantation, and found that the survival is similar in both groups. The difference in the rate of side effects is similar in both groups. So muscular dystrophy is an indication for heart transplantation if there's cardiomyopathy. Phosphodiesterase inhibition with sildenafil is under trial. Polyaxamer, the synthetic material that improves compliance, is under trial. Non-cardiac considerations that affect the heart. So the respiratory care is very important. You have to find out whether the patient needs non-invasive positive pressure ventilation. If this is needed, it should be given because it will protect the heart. Pneumococcal and influenza vaccine should be given so there is no recurrent respiratory infection that will give strain to the heart. Optimal exercise should be prescribed for these patients. Nutrition should also be monitored because they should not put on too much weight. Mental health is also important. Now, this is a reminder that other diseases also have heart disease, and only thing there is not much research in this. MELAS, this is a Holter monitor showing a 10-beat episode of non-sustained ventricular tachycardia. This is Kearns-Sayre syndrome, where you can see the P waves appearing without the QRS complex, and this heart block in Kearns-Sayre syndrome. Pompei's disease, here you can see the tall R waves in the V4, V5, and V6, and also the short PR interval and the Q in the lateral leads. Wow, one AVL, V5, and V6. That's very characteristic of Pompei's disease. Pompei's disease, this is the echocardiogram, the 4-chamber view showing the hypertrophied walls of the left ventricle. Now, indications, this is myotonic dystrophy. Indications for electrophysiological studies in myotonic dystrophy. When there's families, so once we make a diagnosis of myotonic dystrophy, we don't immediately think about the heart. But now we have to get tuned to this. You ask for a family history of sudden death, ventricular fibrillation, sustained VT, whether anybody has had a pacemaker implanted. Then you ask for symptoms of palpitation, syncope, dizziness, because it is the heart involvement that lead to death. So you look at the ECG, the Holter, look for AV block and bundle branch blocks. Sinus node dysfunction, you have to do a loop recording. Look for a sinus pause for more than 30 seconds. Supraventricular arrhythmias also have to be looked for, ventricular arrhythmias. So the conclusion, cardiomyopathy is the leading cause of death in children with muscular dystrophy. However, with early detection, medical intervention, and multidisciplinary care, quality of life can be improved. Thank you very much for your patient listening.
Thank you, madam, for that excellent review on cardiomyopathy. And it's such an important topic. And as you rightly said, that we tend to forget about heart. Is absolutely life-saving thing. And we must be looking at heart in our patients more closely. Any questions? Anybody has any questions? So, madam, I just wanted to ask this: does Becker has more cardiac involvement than Duchenne?
That is what is written. I have to review once more, but all the studies have been done on Duchenne muscular dystrophy.
Yeah. Some literature says that the Becker has, in fact,
has more cardiac involvement.
Cardiac than Duchenne's. Dr. Vishnu? Any question? Any comment?
I think it's too late for everyone to keep up with everyone now. It was a great meeting. I think good that we have a meeting at least every 2 months, and we can update ourselves on the neuromuscular disorders. Yeah.
So thank you so much, all. Excellent session and treatable neuromuscular conditions which Dr. Vijayan and his team showed. Fantastic cases, and Dr. Ashok Ramakrishnan took us through all the scoliotic, spines and how to deal with them, and then excellent cases. And finally, Madam Ives, cardiomyopathy, which was too good to listen. So I think we can close now. Good night, all, and thank you so much. And
Thank you so much.
Madam, for being a program coordinator, and thank you so much, Madam. Thank you.
Thank you, Dr. Mary.
Thank you and good night. Thank you to all the participants also, delegates.
Thank you, Dr. Vijayan. Thank you.